Do orthodontists still need to extract teeth? What does the refereed scientific literature say? I have found there is no more confusing area in orthodontics than the existing perceptions, real or imagined, for extraction versus non-extraction orthodontic treatment. Why do some orthodontists recommend extractions while others do not? Are the orthodontists that recommend extractions using outdated methods? Or are the orthodontists recommending non-extraction arch development, just trying to tell the patients what they want to hear? In this short video, I will review most current scientific research regarding extraction and non-extraction orthodontic treatment. What claims are real and which are not? My name is Jeffrey Miller. I am a board-certified orthodontist with over 34 years of clinical experience. I have spoken both nationally and internationally on the use of cone beam CT imaging as it relates to orthodontic diagnosis and treatment planning. For a variety of reasons, orthodontists seem to have put themselves in camps regarding the willingness to extract teeth in conjunction with orthodontic treatment. Although you will find many orthodontists claiming that they can treat every case without extractions of permanent teeth, I have never heard an orthodontist claim that he treats every case with extractions. Unfortunately, competitive pressures between orthodontic providers has biased some treatment recommendations in the directions of telling patients and parents what they'd like to hear versus what is actually the best treatment approach for that particular patient. Every orthodontist with more than 15 minutes of experience quickly realizes that parents and patients prefer to hear non-extraction treatment. As an orthodontic specialist, claiming that you prefer to treat your patients without removing teeth is like saying you prefer peace over war. It is a given. The universal truth is that orthodontists, and I mean every orthodontist, is going to avoid pulling teeth if there is a better or equal alternative. Unfortunately, the reverse argument is not necessarily true. There are orthodontists who will attempt to treat every case without pulling teeth. The rationale for this non-extraction arch development treatment philosophy has more from concerns over the temporomandibular joint, or TMD, to facial aesthetics, to most recently airway issues. Is this a legitimate concern or just a rationalization for these types of treatment philosophies? John Stuart Mill said, "He who knows only his own side of the case knows little of that." It goes on to say, his reasons may be good, and no one may have been able to refute them. But if he is equally unable to refute the reasons on the opposite side, if he does not so much as know what they are, he has no ground for preferring either option. And I think those are very, very wise words. So let's talk about perspective. You can see in the cartoon, one guy thinks this is a 9, and the other guy thinks it's a 6. One example we can give is regarding the election that occurred approximately 2 years ago. And if we were to ask the question, is Hillary Clinton an advocate for women's rights? I think it would depend on where you get your information. For example, if you were to listen to MSNBC, I'm sure you would have one perspective. And if you were to listen to Fox News, you would probably have a completely different perspective. This is called confirmation bias. You make up your mind, and then you go and seek out sources that support, in our case as orthodontists, our treatment philosophy. There is extreme views on both sides of the equation, but I want to listen to a short YouTube clip from this gentleman. He's an orthodontist. I'm not sure where he practices, but listen to his rationale.
So next question is the impact of extracting teeth that are crowded and closing the spaces.
Right. Well, I should qualify this in the responding to extraction of teeth. And I had a practice over 30 years ago where I probably extracted in 50 to 75% of the cases. I don't even want to know. But for a lot of reasons, I started slowly to get away from that. And now for over 30 years, I basically haven't removed permanent teeth. A recent study in a journal showed that, which was an interview that people responded to, 99% of the orthodontists are still taking out teeth at some point or another. That means that 1% are not. That would put me in the 1% because I'm not doing it. Some would view me as some kind of a crazy person because I'm not, but I have no reason. The people I've treated now in the last 30 years are no different in the population than those I treated before. The only difference is I've chosen to not remove teeth for them. We've been taught as orthodontists that if you push the teeth forward, the gums are going to recede. And yet we have articles in the refereed literature within the last decade confirming that that's not going to happen. I've been doing it for 30 years, done to family members, and I've been reopening extraction spaces for people since 1989, reversing the extractions that they've had, getting rid of sleep apnea for some patients, pain patterns for many, and improving facial balance for lots of people. And I don't see the gums recede, so I'm not worried about that.
If 99% of the orthodontists disagree with him or his treatment approach, I think that should open his eyes a little bit. Gingival recession has increased in the first world countries where orthodontic treatment is readily available. This study out of Israel suggests that the increase in gingival recession could be related to the compromised post-orthodontic tooth position in cases that were overly expanded. In other words, the tooth was pushed past the limit of the bony housing which supports the tooth and gingival tissue. I had a hard time finding scientific study that supports the orthodontist in the video's views. However, I did come across this study out of Denmark which claims expanding or flaring the lower incisors is not related to tissue recession. This study is so flawed I'm not sure it would get a passing grade in a high school science project. For example, it starts out with a justification for non-extraction treatment by suggesting a correlation between extractions and decreased facial aesthetics. This thing has already been studied many times and been disproven. Although we do not have time to review the study, it did show a statistically significant relationship between increased tissue recession and orthodontic expansion for individuals, but when you took the group as a whole or mean measurement, there was no statistically significant measurement. What about extractions versus non-extraction orthodontic treatment and its correlation to temporomandibular dysfunction syndrome, or TMJ as some people call it? Well, there again, there's numerous studies have determined there is no correlation between extraction and non-extraction orthodontic treatment and jaw joint problems. What about airway? Is there a correlation between extraction orthodontics and airway problems? Absolutely not. I've heard this mentioned and it has no basis in any reliable scientific publication or reality. In other words, airway is not an argument for or against orthodontic extractions. You sometimes hear that extraction orthodontics will cause a dished-in profile, referring to the area of the profile between the tip of the nose and the chin. Good scientific research, which asked orthodontists to identify extraction cases by looking at before and after profile photographs, showed that the dished-in face could not be correlated with extraction orthodontics. This image, which demonstrates a concave or dished-in profile, was treated without the extraction of teeth. This orthodontist made a video contrasting twin sisters, one who supposedly was treated with extraction, although he shows no photographs of the teeth themselves, and the other was treated without extraction. He is trying to make a point that the twin that was treated with the extraction has a less desirable profile. Looking at the photos, you need to ask if both profile photographs are taken with the same facial expression. For example, it really appears to me that the twin's profile on the left of the screen is forcing a captured upper lip to exaggerate the point he is trying to make. Numerous studies have disputed any claims of profile changes. He makes a further point of showing the frontal photos. Obviously, the facial photo on the left does not look as appealing to the right. But even an amateur photographer could easily tell that these photos, which he's trying to show a less desirable facial treatment result, were taken at different focal lengths. The shorter focal length causes the middle of the photo, or in this case the mid-face, to appear distorted. Just to illustrate my point, I googled portrait focal length. Notice how the face is less attractive with the shorter focal length versus the longer one on the right. Obstructive sleep apnea is a very serious medical condition. It is directly related to many health issues. We all agree that sleep apnea is a very serious condition, but is it at all related to extraction orthodontic treatment? Again, reliable scientific studies contradict any relationship. It is fascinating that some sleep apnea and airway focused orthodontic providers would hang their hat on two-dimensional lateral x-rays to diagnose airway issues. This is almost laughable. They are only looking at one plane of space, which makes evaluation of the airway impossible. So why is this information mission critical for anyone that is orthodontically moving teeth? Simply stated, bone does not remodel significantly at the outer bony wall. If the tooth is moved through this wall, you get dehiscence or fenestration of the bone. It is still unclear if and when this bony defect will lead to a gingival tissue recession. Dr. Moraes et al. Studied 22 adolescent patients with crowded dental arches. These patients were treated with a non-extraction arch development strategy. Post-treatment cone BCT concluded that both vertical and horizontal bone losses occurred. Since the lower incisor area generally has the smallest bony housing, it is the most susceptible to bone and tissue recession. These photos, which I downloaded from Google Image, are examples of tissue recession. Thanks for listening. If you have any questions, feel free to email me at drmiller@orthodonticassociates.com. Thank you.